We shall now go on to our next speaker, Dr. John SARKAR, who is practicing at Shushrut Eye Foundation and Research Center, Calcutta. Again, a very dynamic cataract surgeon, and he is going to lead us through combined surgeries. That is when a pterygium is also present, and with a conjunctival autograft, and his practical tips in how he protects the conjunctiva, doing an SICS, and also taking care of the pterygium.
Again, starting. Very good evening to all of you. I'll be presenting nuances of pterygium surgery. So the plan of presentation will be the basics of pterygium surgery, different methods, how to approach in combined procedure, and when trapped, how to come out, and what are the technique messages. So it is why important because it's your tip of iceberg. Because it's the first surgical experience in the for the resident, exposure to the ocular surface surgery for his first surgical learning curve and a good outcome. Lots of things to learn from it. So this is actually I'm sharing one of the basic surgical technique of the. So I'll move on the slides. So why it is important? Because first surgical experience in the for the resident, and exposure to ocular surface surgery and the first surgical learning curve and good outcomes are there because lots of things is like a tip of iceberg. So I'm sharing the first of the basic. My
yes.
Yeah. Okay. So this is actually I'm showing one of the just how to dissect the things. It is with the cataract surgery or without the basic surgical technique will remain same. We have to dissect the things. Remove all the tissue and then followed by the grafting will be there. This is the basic technique for the things. So once it grafted there, it can be if you don't have the options, if you're resident one, they can use the tangible sutures for this the purpose for security things. But probably autologous blood can serve the purpose also. The same thing we can see with autologous blood. This is a huge heptic pterygium was there. The graft was there by the autologous blood, and is for 6 weeks post-op. You can see absolutely the clear cornea with the graft in situ. So this is another year which is the fibrin glue which doing our task very easy. We are removing the graft. Place exercise these things and placing the fibrin glue and place it over there. It reduce the time as well as more secure the things. So I'm not going in details of the things. Now these are the complications of the grafts, whether it what are the graft compliances. Now I will move to our main talks. When the bilateral pterygium is there, we are using the AMT. This is another video. Once it is removed, we cover the whole ocular surface AMT and secure with fibrin glue, taking the graft from the superior temporal part and making small nicks over there and just place it at the limbus in either of the sides as a border like things, and they will and secure them the surface and placing the base. So these are actually basic pterygium surgery. Now, and you can see this is a pre-op, this is a both head and this is a post-op. Now, what happened? How when the patient comes with the pterygium, the cataract, so how to approach us and is single or the stage procedure combined, or what will be the biometry, or it is SICS or PHACO. So sequential surgery or it's a combined surgery. When should I sequential? When the pterygium is extensively high, it covering almost encroaching central visual axis, and we are getting the abnormal visibility, or there is a key reading is abnormally coming. So better in those situation, or it's double-headed pterygium, or it combined the cataract. So better to go ahead with the first pterygium surgery, stage surgery. Then when the predictable surface is quiet and the predictable key reading get, then we'll better go ahead with the cataract surgery. Then what will be the biometry if you're combining for the cataract surgery, SICS or PHACO with the pterygium? If the pterygium is not involved with the central 4 millimeter, then we can go ahead with that because we can get the clear K Meyer. Then we can do the formulation. It's my standard K or your SRK formula, which will be the K rating. If the grossness or the K rating is decided, then we can do by the topographic K or same K. And what will be the post-operative refraction? Definitely, whenever there is a pterygium is there, they usually aggravate the with the rule astigmatism. Whenever so, we should predict the things. Whenever we remove the pterygium, so definitely the pushing part is withdrawn. So usually they push the eye in the myopic shape. That should be considered while planning for the combined surgery. So I'm just sharing one of the patient. This lady having the heptic pterygium with the NS3, and we are doing the topography. This topo is showing this patient almost 7 days after patient having the astigmatism was there. You can see that the steeper curve is approx 44 and the flat curve was 37. And what we planned for the we have done with the biometry. The center as the central K was clear, we can get the only the 44 and 43 the K rating in the system. So we have done simply the clear cornea PHACO here, temporal approach, and do the pterygium surgery and taking the graft from the superior part. And you can see post-operatively, though there is a high hyper of patient, the biometry of the patient having the 26 biometry power, and post-operative there is no single astigmatism, and he having the 6/9 vision without an astigmatism. So I'm just sharing of the combined surgery video. So these are actually combined surgery planning for the PHACO. Sorry, you can see my videos are visible, ma'am.
Yes, visible.
So after doing the RECURRENCE, I noticed that the visibility is not. I'm not taking the inferior temporal part. So what I move on to, I remove the head of the pterygium to increase the visibility. So if you're planning for the surgery for the combined even also SICS also, then if there is visibility is poor, if you combine plan, then we can just remove the corneal part. Then for once the cataract surgery, either of the SICS done, then you can complete the procedure. I'm just showing the successive part of that surgery. So once the cataract part is done, we are doing the subconjunctival decision of the pterygium tissue. This is the subconjunctival excised must. Wipe the things. We are taking the tissue from the superior part and mark for the resident. Even also not marking is must because once it's very thin conjunctival graft, you may revert the thing. So better to stain the thing. If you don't have the marker pen, even you can stain it with the trypan blue, which is used for your antrocapsule staining. So place it in the proper orientation. Once hemostasis is achieved, we place it over there. It is so thin. And the remaining part I cut, and there is a, so it's well covered by the pterygium. The base is well covered with the and secured fibrin glue. And the host side also secure. So this is one of the slides I'm sharing. This patient came to us immediately. Somewhere it has done the pterygium surgery with the SICS, and he came with us this type of and graft having the subconjunctival hemorrhage. So this is actually what we have done. They have the remaining part also. Pterygium graft was not properly cleaned off. So whenever we are planning for the combined, so I don't have the personal slides for the combined SICs with the pterygium. What I want to share for by the slides, if we are planning for the pterygium surgery with SICs, so better hemostasis should be there. Sometimes what happens whenever we are doing the pulse surgery SICs, we don't and cauterize the muscular tunnel or while conduct a subcutaneous bed. So better in those cases, selective cauterization of the conjunctival bed for nice tunnel. And whenever we are planning for the taking the graft, as already we are cutting the superior conjunctiva, so we can harvest the conjunctival graft from the inferior temporal part and place it properly. And while we are actually this patient already graft was there, we didn't remove this graft. Simply I've taken the patient and I dissect the thing and the remaining part of the residual which was left behind. And this is after the 2 weeks of the 3 weeks of the first presentation to us. And whatever the FACO and SICS, definitely either of the one can be done. But if SICS also with the resident doctor when they are planning for the cataract surgery, if it is encroaching central part visibility is poor, in those cases better to go ahead first. Your FACO pterygium one, and once the surface will be stable, the care will be proper and visibility is good, and then you can plan for the stage SICS. If the pterygium part is very nominal, in the combined SICS and pterygium can be planned. This is some of the complication, the recurrence, which is the most common of these things. And this is one of the things I want to share this thing. Sometimes some of the person using for the recurrent pterygium, the mitomycin has been used. So these are the patients, whenever you are planning for the pterygium boost and combined with the cataract surgery, if you are using the mitomycin to prevent the recurrence, it should be used proper and judiciously, because your inadvertent exposure time that causes a melting of the sclera. This patient came to us with after 1 month of the cataract surgery, and their superior wound was so bad, and because tunnel was done superiorly and from the nemboral part, that's why melt was there. So whatever this you can see, this melt was there. We have done the debridement of the tissue, and then the scleral patch up done, and followed by CH. And these are the 6 weeks after the. This is the ocular surface reconstruction, and you can see these are the primary pterygium site, and this is the superior part where the graft was taken. So these are the from some of the complications. Infection can be there, and these are scarring. And if there is residual after the cataract surgery, if there is a residual, astigmatism is there, it can be you can wait for some time to stabilize the refraction. Don't jump for the any surgical procedure first. Even if residual scarring is there that causes the your cylinder parent, then we can trial, give the RGP trial, or we can give the plan for the if it is persistent and patient is very much keen for the visual rehabilitation, then in this case a PTK can be tried. So technique messages are: pterygium surgery management should be in molecular and cellular level. Sequential or combined cataract surgery should be planned according to the case with maximum outcome, which I have learned from the previous speaker too. Also, whatever we are doing, we have to give the rational way. Ultimately, that patient should be happy the next morning, and I should be quiet. Early detection of the complications and the prompt action against it must and never be and hesitate to refer your patient whenever you think that the things are not amenable by yourself. Thank you very much. Thanks for your patience. And these are some of the relevant studies I chose, and which is really good. Well, thank you very much.
Thank you very much, Dr. John. Now we shall go on. Could you stop sharing your screen?
Yes, ma'am.
Dr. Deepak, are you there? Dr.
Yes, I am there.
Yeah. Now, if it is a old patient, glaucoma suspect, and the kind of cataract which makes you think it's better to do an SICS surgery, where would you locate an incision and where would you get the graft from?
Well, that's a very tricky situation. See, if you're planning for to spare for future trabeculectomy, I think that is much that higher rating. So we need to more cataract incisions elsewhere. So I would definitely do a temporal incision with an inferior graft. So most for my pterygium surgeries, I always use the inferior graft. That's not a big issue. For SICS, again, I'll go and do a temporal SICS with an inferior graft. For most pterygium surgeries, I always use an inferior graft.
Yes.
And as far as the combined surgery, sequential surgery are concerned, when you are a cataract and a PHACO surgeon and you're using a SICS and a PHACO surgeon, and SICS is a bailout situation in very advanced dense cataract, leathery cataracts or a pupil, small pupil and all those kind of situation, and a very old patient. Would you still be firm about removing the pterygium, waiting for the case to stabilize and then do a cataract surgery? Or because now all of us are very conscious of doing every surgery as a premium surgery. Would you wait or would you do it both at one sitting? And what's your reasoning for that?
It purely depends upon the need of the patient at that particular scenario. If the patient is desperate for vision, then we have to sacrifice perfection there. So I would not hesitate to do just only cataract surgery or do a combined cataract and pterygium surgery. Although the refractive outcomes will be less than optimal, but depending on the need of the situation, the patient requires an urgent visual rehabilitation. She's elderly, he or she is elderly, and the cataract is very dense. And these are situations where I would deal with the cataract first or deal with the cataract along with the pterygium at the same setting. Otherwise, if the visual needs are not so desperate, my usual go-to strategy is always deal with the pterygium first, allow the cornea to stabilize, the astigmatism stabilize, then plan for cataract surgery accordingly.
Yes, yes, exactly. Those were my thoughts. I just wanted to hear it from you. Dr. Ravindra, I wanted to ask you, for a learning surgeon who's going to be suturing the graft and doesn't want to use a coffee glue. So what would be the tips you would give for suturing pterygium graft, and when should sutures be removed?
Suturing is not something which is really bad, and it's a good alternative for the glue. I think, Dr. Kamaljeet, if you can mute your audio, whenever you muted, we were not hearing the noise. Okay, no, fine. Thanks for that question. It's a wonderful analysis of his cases. Suturing is not a bad idea at all. We have been using sutures for such a long time. Suddenly, because of the glue availability of glue, it has become bad. So when you suture it in such a way that the knot goes inside. You start from the inside the conjunctiva and go out, and knot goes inside. So post-operatively, you're going to be very comfortable. There won't be any discharge and irritation and all those things to the patient. Many times post-operatively, they fall off. 2-3 weeks later, you'll see that they're gone. And otherwise, you can always snip it with a needle and pull it out with a forceps post-operatively. Probably about 10 days to 15 days is a good time to remove the sutures if you have applied them.
Yes. Yes, very true. Shall we go on to our next speaker? I think.
Yeah. You can use blood also. Sorry.
Yes, Dr. Boramani. Yes.
You can use autologous blood also. That works very well as a glue.
Yes, yes.
Yeah, I agree with you, sir. Most of the surgery, whatever you're doing, ocular surgery, even if it is extensively ocular surgery reconstruction, that time we are preferring the glue if it clamped up with AMT or slits. Otherwise, if it's simple pterygium, autologous glue, it does nicely work.
Yes. Yes.
The other one, the suture that I would recommend is 10-0 monofilament nylon, which gives the least amount of irritation, and cut it right on the knot. So that doesn't give any inflammation or a stimulus for the growth of blood vessels or recurrence of pterygium.
Yes. Absolutely. All very